Can I request you to switch on your videos, please? Yeah, perfect. Great. So good morning, everyone, and welcome to this event. First of all, let me thank you for coming here today. It's a long weekend, it's the Dussehra season, but still you are able to make it here. That's great. It's an honor to have the opportunity to discuss our topic with a distinguished panel of experts working in the area of primary healthcare in India and abroad. I thank them for the time out of their extremely busy schedule and coming here to enlighten us. Let me start by introducing myself. I am Dr. Praveen. I lead the primary healthcare program at the George Institute. I also coordinate the Primary Healthcare Research Consortium, which is a global consortium and hosted at the George Institute for Global Health in India. To discuss more about the consortium, may I request Professor Bob Maas, also known as Dr. Robert Maas, who is the chair of the research consortium, to talk about the origin and the work of the consortium. Professor Bob Maas is a distinguished professor in family medicine and primary care at Stellenbosch University in South Africa. He is editor-in-chief of the African Journal in Primary Healthcare and Family Medicine and president of the South African Academy of Family Physicians. Over to you, Bob, to introduce the research consortium, please.
Great, thank you, Praveen, and good morning to everybody from South Africa. I can't see you, but I assume you are there. Let me just share my screen, Praveen, and then we'll get started. Great. I'm assuming you can see the slide.
Yes,
Am
Bob.
I right?
Yep.
Okay. Right. So yeah, so just in a few minutes, I'm going to introduce the Primary Healthcare Research Consortium and how it came to being and what it's about. And of course, as Praveen said, I think this event today is being hosted by the consortium. And so as Praveen said, I'm the chair of the steering committee of the consortium, and tell you a little bit about how it came into being. So the idea for this consortium, I think, started in 2016, and the real motivation, I think, behind it was to try and identify, really at a global level, the priority areas for research into primary healthcare in low and middle income countries. So it's very much focused on LMICs. And in addition to sort of identifying those priorities, to try and build a network of researchers to collaborate on addressing these priorities, and then to actually go and perform the research to answer some of these questions. So the people who came up with this idea and initiated this whole thing were within what's called the Primary Healthcare Performance Initiative. And this diagram here is their framework for understanding and measuring primary healthcare, which has actually very much informed the recently published measurement framework from the World Health Organization. And then the other group that were there at the beginning was the World Health Organization's Alliance for Health Policy and Systems Research. And then the whole endeavor was funded by Bill and Melinda Gates through Ariadne Labs. So the process that they went through was, initially they did this scoping review on primary healthcare system performance in low and middle income countries in an attempt to sort of sketch out, where the evidence for primary healthcare was strong and where it was weak. And following this, there was a priority setting meeting with many stakeholders and a Delphi process, which then led to a call internationally for people to propose how they could sketch out in more detail the evidence gaps in these 4 areas, which is the 4 areas that they sort of highlighted from this whole process. So the 4 areas were in policy and governance and financing, and then in quality and performance management of primary healthcare and the different models of care that are appropriate. So, and I'll show you who responded to this call just now. I think there were about 6 different organizations across the world that responded. And for a couple of years, 2018, 2019, they did this work on what are the evidence gaps in primary healthcare, and what are the priority research questions. And in fact, all of this body of work was then published in the BMJ Global Health Supplement in 2019. So if you're interested to delve into the work around the priority questions and evidence gaps, then you can go have a look in that supplement. So then these were the organizations that did that work, and which then actually founded and became the members of the consortium. So just to run through them, so we had the American University of Beirut, which is based in Lebanon, the International Center for Diarrheal Disease Research in Bangladesh, and then the Primary Care and Family Medicine Network, or PRIMA-FAMED, in Sub-Saharan Africa. That's actually where I came in as also the coordinator of this network, which is based at Stellenbosch University, where I'm sitting in South Africa, but includes, I think, about 20 countries in the region. So then we also had the George Institute for Global Health, based in India, which is where Praveen comes into the picture, and actually which is where the consortium has been organized from and coordinated, as well as the same organization in Australia. We also had the World Organization of Family Doctors, or WONCA, which of course is a global network, so actually covering probably the majority of lower middle income countries in the world. And then finally, the George Washington University in the United States of America. So these are the people that joined hands to do the work of the consortium over sort of 2020 and 21. In fact, we had our inaugural meeting, I think it was in early 2020, literally sort of hours before the world shut down from the COVID pandemic. So the vision of the consortium is improving health through strengthening high quality, person-centered primary healthcare in lower middle income countries. And the mission, how we go about this, is through obviously having LMIC-led research, both developing, capacitating, conducting, and disseminating such research, and trying to do research that addresses these priority knowledge gaps so that policymakers might actually be interested in the findings, and research would be implemented in policy, and catalyzing a global network of collaborating partners. We also have an advisory committee, which is quite an interesting group, led by Emma Ariarte from Latin America, and Rajani Fed, who I think a lot of you probably know, Robert Martin from the World Health Organization, Sharina Siddiq from WONCA in Malaysia, Koku Owenor-Williams, who was previously from the Ministry of Health in Ghana, Jeff Markins from the Primary Healthcare Performance Initiative, and Itai Rosike from sort of a civil society, really, in Zimbabwe. So the initial research that we've been doing, so in fact 2020, 21, as you know, was a tricky time to be doing any research with the COVID pandemic, but we've been working on these 4 research projects, which are all basically now finished, and the findings hopefully will be published in the next few months. The first one was looking at the relationship between how different countries formulate their primary healthcare teams and the ability of those teams to actually deliver comprehensive primary healthcare. And this was done in Mexico and Uganda and India. And then the second one was looking at how different countries are using, in essence, data on primary healthcare performance information, and what are they collecting and what are they using in policy making. And this was done in El Salvador and Lebanon and Malawi. And then, of course, we had the COVID pandemic. We had a global survey on how public health and primary healthcare worked together or didn't work together in the COVID-19 vaccination campaigns. And it was a collaboration with the Bezroor Center in Canada. And then finally working in collaboration with the Global Alliance on Chronic Diseases, who of course are funding like dozens of projects around the world. We had a project to look across all of the projects funded by the Global Alliance and what they can tell us about sort of effective models of care in primary healthcare for the management of non-communicable chronic diseases. So, hopefully all of these will be published soon, and you'll be able to see what we have learned in these areas. And then finally, you can also get more information about the consortium. There's a website, phcrc.world. And I think there's still a webinar series that's happening to share some of the findings and also engage with people on important issues. And I see we also supported that little icon there, the AFRI1 icon. We supported a regional e-mentoring program in sub-Saharan Africa for novice and emerging researchers. So going forward, the consortium is looking at new work, particularly in the area actually of community-orientated primary care, or what some people call population health management, and community engagement and participation. I think these are some of the key new projects where they will be focusing. So Praveen, that I think is my introduction as to who we are and where we're coming from and where we're going. But back to you.
Thanks, Bob. That's a wonderful summary of the research consortium and the work that we do. So now, without any further ado, maybe we should start the scientific session for which we are all here today. We all know that comprehensive and holistic primary healthcare system is an ally in the achievement of universal health coverage and sustainable development goals. But research shows that while healthcare policies and programs rely heavily on technical research in pharmaceuticals and equipment, when it comes to service delivery of primary healthcare, the evidence-based healthcare policy and program making and its cost effectiveness and inclusive implementation, it has been relatively absent in India. There is an increasing need for the policymakers and implementing agencies to know what works and what doesn't, and for the academics and researchers who are here to create robust, quality, and quick evidence for policymakers to utilize it in the policymaking processes. Integrating social participation in evidence generation is also key and vital in this process. Evidence-based primary healthcare policies ensure resilience, which is vital for improving the quality of life, the efficient use of resources, and equitably meeting population health needs. By the end of this session, we think we will have understood the need of using the local and contextual evidence for strengthening the primary health care. We will also discuss the importance of political stewardness in creating equitable, resilient, and comprehensive primary healthcare systems. We would have discussed various ways to strengthen the evidence-based healthcare policymaking and use of data for effective implementation of the policies for the government and for other stakeholders. And we would also have discussed the emerging challenges and gaps in PHC evidence generation for policy usage. Following this event, we are planning to develop a report of this event, and we will be developing a policy brief which highlights the challenges and solutions discussed along with the recommendations for the policymakers. And we also will use the learnings from here, through the consortium members for a more generalized use globally, because we expect the challenges that we face here to be similar all around. As I said before, we have a wonderful list of panelists to discuss the breadth of this topic. A few of them were unable to come to the event, but have kindly joined us on Zoom, and many have traveled to this place to share the knowledge with us. Let me introduce our first panelist, Dr. Rajiv Sadanand. Dr. Sadanand sir is the founding CEO of Health System Transformation Platform. Prior to taking up this assignment, he has a career of civil service officer with specialization in health systems and health financing. He held 3 terms as Health Secretary of Kerala. And during these stints, he initiated the transformation of health systems with a focus on primary healthcare, designing and executing disease prevention and health promotion programs, and integrating the social and epidemiological determinants to healthcare. He also was the key to apply technology to improve the primary healthcare delivery in Kerala. So he was the CEO of RSBY, the India's National Social Health Program. And currently he's a commissioner on the Lancet Global Health Commission on financing of primary care, and also a honorary advisor to the Chief Minister for COVID pandemic. So can I request you to please come to the dais? Our next panelist is Dr. Sanjeev Kumar. So Dr. Sanjeev Kumar is a preventive and social medicine physician with around 5 decades of experience in more than 30 countries worldwide. He was the Dean and later Director of International Institute of Health Management Research in New Delhi. And he has also worked as Executive Director at the National Health Systems Resource Center, Ministry of Health and Family Welfare in India. He led the development of many policies and strategic documents to improve health in India, including guidelines for treatment of conditions of public health significance, and contributed to the National Health Policy in 2017 and in 2021. Dr. Sanjeev sir, can I request you to please come to the dais? Next, we have Dr. Neha Dumka. He is a public health professional with experience in field of implementation, evaluation, and research in health systems, including primary healthcare. He has a vast experience of community processes, comprehensive primary healthcare, public health planning and administration, and program evaluations in public health organizations. She is presently working in the field of health systems and research under the Knowledge Management Division of the NHSRC, Ministry of Health and Family Welfare, to support the program implementation by collating the evidence and knowledge from the field spanning across national health programs. Dr. Neha. We have Dr. Krishna Reddy, so who is a board certified cardiologist, internationally known in the areas of comprehensive primary care, digital health, and integrated care, with a long history of working to improve the health of people in South Asia. He is currently the Regional Director, South Asia for Access Health International. Dr. Krishna Reddy. We have Dr. Indranil Mukhabde. Dr. Indranil is a professor and health economist at the School of Government and Public Policy, O.P. Jindal Global University. He is joining us online through Zoom. He holds a PhD in public health and health economics from JNU and has 17 years of research and teaching experience in the field of health economics and healthcare financing. And he will be providing his insights into these aspects today. Additionally, he has led several research studies that have been supported by the Department of Science and Technology, Government of India, by the WHO, by the ILO, and NHR in the UK. Welcome, Dr. Indranil. We have Dr. Arnab Mukherjee. Dr. Mukherjee is an applied microeconomist whose work focuses on the economics of healthcare and governance. So Dr. Mukherjee is interested in how survey and administrative data can be used to inform public policy. Again, a topic which is very important for discussions today. He has been using this in the context of health, where he has been studying the impact of social policy on health outcomes, and also in the context of how governance impacts the economic growth. He is an avid writer. His research work has been published in many international journals of repute, and some of his work has also been quoted in widely read media. He has been a consultant with the government of Karnataka, Bihar, the World Bank, and the Asian Development Bank from time to time. Welcome, Dr. Arnab. We have Dr. Silpa Karvande. She is a public health researcher and an anthropologist by training. She is joining here from Pune. As a PhD in public health from the University of Basel, Switzerland, she has over 25 years of experience in research and training at national and international level. Her primary areas of focus are health system strengthening, quality of healthcare, maternal and newborn health, and communicable and non-communicable diseases. She will be providing again an insight from the ground level experiences that she had over the span of years. Welcome, Dr. Silpa. And last but not the least, we have Dr. Bob Mass, who is joining us as a panelist to give us the perspectives from a global view and from that of the research consortium. Welcome, Dr. Mass. With this round of introductions, let's start our discussion. My first question would be to Dr. Rajiv. Sir, we are here to understand, what policies, how are policies actually made in our country? Can you throw some light into how healthcare policies are being developed and rolled out in India?
Fortunately, I've retired and not bound by the Official Secrets Act, so I can reveal a state secret of how policies are formed. Well, there is hardly any specific ways in which policies are formed, because in health, what happens that most of it responds to an emerging situation or an emerging challenge. For example, when you look at the non-communicable disease situation in Kerala, which has got about 30% prevalence of hypertension and 20% prevalence of diabetes in the adult population. So, if we had evidence in the 90s that this is going to happen, or we had systems of picking up that this is happening, the primary care strategies, I won't say policy, the primary care strategies of Kerala would have factored that in, and then the overwhelmingly RCH and infectious disease focused primary health care policy of Kerala would have been amended it would have been amended, and frankly, Kerala may not have landed in that mess it is today. I can't blame anybody, because even in 90s I was a health secretary, so there's no one else to blame. But the point is that what would have helped us understand this, having a good information system, which would have helped us see in the emerging scenario. And like in the European countries, they have this OECD countries, they have the observatory, which tracks the epidemiological profile, and then uses that information to modulate policies. So in an ideal scenario, the policymakers, what they would do well to do is to look at the evidence that is emerging, which also means that they develop information systems that come up with this information and modulate their policy accordingly. My problem is that I would stop unless I'm asked to stop.
Sir, please, yeah,
okay,
please go on. And
okay, let me cite another instance of what happened. India has a wealth of evidence which unfortunately is not fully used. And one of the things that in my present job I'm trying to do is to try to identify the sources, triangulate the data, and then come up with dashboards that policymakers and implementers can use. For example, in the 2014 NSSO data, what came out was that the 34%, only 34% of the primary care utilization was done in government health systems. The rest of it was going to private sector. Now, NSS also asks a very interesting question, which is to the people who did not go to a government hospital, why did you not go? And the first question is that lack of poor quality. Then there are issues like overcrowding, lack of specialization, distance too far, and all. So when the health secretary of Kerala looks at that data, the question that he's going to ask is, are the government health systems not being used because of lack of access, which it is not? Lack of quality, you'll be surprised it was not. Only 2% said that they don't go to government facilities for lack of quality, because the quality in government health systems is highly respected. Two reasons given was, one was the overcrowding, and the other one was lack of specialization. So when we were designing our primary care transformation in 2016, this is what guided us. How do you make the patient's experience good when they come to the hospital, so that the crowd is managed better? And secondly, how do you enhance the specialist services that they want? It may not be the best solution. What I'm saying is, how based on available evidence, policies can be reformulated and then to respond to a situation. If we had advanced information, our policy making would have been better. I'll stop here. Thank you.
Right. So Dr. Rajiv, just again following up from there. So you say for policy making, good advanced information system is required. Apart from that, do you envisage, are there any other things that are important for policy making, especially around primary healthcare, if I can talk about?
No, there are also, you see, this is what will come up with identifying the need. But the problem is that quite often we respond to it with no evidence based as to what will work. Now, when I was health secretary for the second time, we had the good fortune to get funding for trying out some of the elements that later went on into our transformation process. We picked up 3 primary health centers where this was run. It was studied, and the results of that actually went into forming the policy on this. I have more time?
Yep.
Okay, great.
Please. No, I mean, we just
you
keen
can't
to
stop
know.
me anyway. Now, the next issue that happened was when we were designing this primary care in 2016, another thing we realized was that if you had a diabetes prevalence extending over so many years of 20% prevalence and a horribly bad control level of just 15%, the end organ damage must be so high that it cannot be managed as it was being done by tertiary care institutions. So you had to bring it down. You had to bring it down to the primary care level. Now that was a big ask. Can you do it? Can the primary care system handle it? So when we got an invite to participate in a diabetes-related international research program, the question we posed was that can we run an implementation research, an actual intervention research, by which using the primary care resources that were available, which had been augmented, is it possible to look for end organ damage at the primary care level and manage them at the secondary level? We ran that project successfully with interesting learnings, and that led to the intervention research, the results that intervention research, the learnings from that led to a policy by which the screening for end organ damage from diabetes was integrated into primary care, which is another instance of how a potential intervention can actually be proved on the ground and then integrated into the overall policy on what primary care should provide.
Great. Thanks, Dr. Rajiv. I won't trouble you more now. Dr. Sanjeev, Dr. Rajiv mentioned that the evidence is also key, along with good information system that can go from bottom up, and Dr. Rajiv also talked about the evidence that they generated, So now, can I ask you whether evidence needs to be generated for each and everything, or evidence needs to be accessed, which is already there? So it could be a mix of both. But again, what are the challenges which are faced by government and other stakeholders, for developing and accessing evidence-based primary healthcare strategies and policies in India?
Thank you, Sudeep. I will conceptually take you from the real world. And in the real world, we look for evidence. So even if, I was talking to some of the people in the morning, what mind doesn't know, eyes don't see. So if you don't know the real world, you will look for evidence which is not really connecting to the real world. So I'll take you one step before the evidence. So if you are familiar with the real world, then you will look for evidence, what is the problem, how it can be addressed, and how we can move forward. So I will take you one step back from evidence, and then yes, you have evidence, and then you start incorporating evidence into policy. You incorporate evidence into policy, there is another gulf between policy and implementation. So to give you an example of National Health Policy 2017, before the policy came out, there were 4 experts groups who looked at it, and one expert group looks at primary health care. And they gave their reports and other three groups, and that finally was the, lot of evidence, lot of work was done. Some primary research was also done. Most of it was review of literature. And then we roped in experts, like for medical education, Dr. Vinod Paul, who everybody knows now. We requested him, can AIMS Delhi take a lead? So he gave inputs into, there's only one paragraph on medical education. So the people who know the real world, you engage them into looking at policy. Coming specifically to what problems we faced in looking at evidence and incorporating that. You may have an evidence, but there may be people who are, so traditionally bound, they are reluctant to incorporate evidence. In this report on primary health care, we had to struggle for including social determinants of health. But I'm very happy finally it is there. So there was another aspect, and if you give me opportunity, I have
Please.
a few slides, and I will take you, because one picture speaks more than 1,000 words. What we were not able to get, and mind you, I was heading the institution which was given responsibility for writing the policy. But there are people in the group who were reluctant to include family level care. And there is nothing. We prepared a matrix, what can be done at family level, because in agriculture ministry, nobody will ever question that if you want to increase agriculture produce, you have to work with farmers and you have to go out and work in the field. The soil, the fertilizers and other technology needs to be there. But here we will deliver health services at the doorstep. What is happening inside the door is not our concern. We struggle with that. And unfortunately, despite evidence, and I will give you a glimpse of what was the evidence, that lot happens within the family, but it was ignored. We were not able to get it there. So that's my take on
Sure.
that.
So Dr. Sanjeev, you said a very good point there, that you felt, or the team felt, that social determinants was important and family was important, but it was not taken into the policy. We would be keen to hear a bit more about what were the obstacles, who said that this is important, who said that this is not important, and why was this not included, that sort of thing.
No, that's again going to the real world, the mindset of the people who are picked up and put as experts in such task forces. Unfortunately, most of the people are medical doctors. They know only diseases and how to treat the diseases. They don't look beyond. And if you are looking at health, 80 to 90% of health comes from outside Ministry of Health. You have water, sanitation, agriculture, pollution. Those of you in Delhi know it becomes even difficult to breathe at times. You go out in the open and you feel the air is so bad. So these are the factors which contribute. And when you're talking of primary healthcare, you have to work on
All the
on social determinants. And the way to work on it is health in all policies. Government is working towards it, but there is one factor putting in the policy and another is how do you implement. We are so much into silos. So the mindset of the people who have been trained in medical school to look after only diseases, and unfortunately, most of the people who are experts in other sectors are influenced by these thoughts. So there were only two of us in a group of about 15 who were insisting social determinants got included, but
right.
Home level care, family level care, how much it contributes, that is still not there. But we'll continue some improvement from the previous policy to this policy. And I'm sure in the next policy, we will have our say and home level care will be included. Thank you.
Great. Thanks, Dr. Sanjeev. Now, Dr. Reddy, what Dr. Sanjeev said, medical doctors only treat diseases, but Dr. Krishna is a cardiologist and he has been working in public health for so long. Can we have your perspectives on this, please?
Yeah, I think take my clinical perspective to address this question. As a clinician, we manage persons. And to manage a person, we spend 20 years in understanding human being. What is their anatomy? What is their physiology? What is their pathology? how to diagnose the pathology, then how to plan managing that pathology so that that individual improves in health as well as we relieve his suffering. So as a clinician, who is actually managing health systems? Is it politicians? Is it administrators? Or is it health managers at a district level? I mean, just like you need to understand a human being to manage a human being, do these people understand health systems, the complex health systems which have been evolving to meet the needs of people? So whoever has completed, say, public health as a professional in this country or anywhere, or whoever is managing the health system, do they have the science of health systems? Do they know the anatomy of health systems? Do they know the physiology of health systems? Do they know the pathology of health systems? Then do they know what interventions can address this pathology? I mean, for example, the out-of-pocket expenses is the pathology. The financial hardship is the pathology. But as a scientist of health systems, I would try to understand what is the root cause of this pathology. So unless you have that systemic change of people managing health systems to be insisted that they have enough knowledge, enough skills, and enough professionalism to manage these health systems, until that changes, I don't think we have a structured curriculum for public health professionals being trained in this country. There are hundreds of colleges offering these public health courses, but there is no national standardization. How do you say that public health professional coming out of this system is competent to manage public health? We don't have that standardization. So that is my clinician perspective. The root problem of this disconnect between evidence and policy making is because we do not have a properly laid structure to manage this health system, which is becoming more and more complex. It's not just public health, it is mixed health systems. So the public health professionals who are trained as a public health, their focus is on public health. They think there is no private health care, which caters to 70% of health needs of the people. So how this policy excludes this private care, which accounts for 70% of, that is one aspect from a top-down aspect of health systems management. The second is the bottom-up. I mean, in medicine, again, I'm using my clinician's experience and expertise. There is a disconnect between bench and bed. That means when you say bench and bedside, bench is the research bench and the bedside is the patient requirement. So we have separated clinicians from the researchers. And the outcome of this separation, because we called it as a conflict of interest. If we develop a drug, we call it as a conflict of interest. We should not be involved in that research. The thing is that because there is a disconnect, 90% of evidence that is generated as a part of the bench research is not applicable to the bedside. But the cost of this 90% of bench research gets loaded to those 10% which reaches the bedside. That explains why the emerging innovations are becoming more and more expensive because of the disconnect. I mean, there was an attempt to connect between the physician and the scientist called physician scientist. The same thing is happening in health systems. There is a disconnect between the bench and the bedside. The research you are catering to the policymaker who is not connected with the people, because ultimately the health system is supposed to meet the needs of the people. So there is a disconnect. Who is the policymaker? I mean, who is talking to the people? Is it the politician? Once they elected, they don't talk to the people. They are supposed to connect. Who is connecting these people actually? So that is again a disconnect between the people, evidence, and the policy. So I think this disconnect has to be connected for it to be effective. So I think so you asked me as a clinician because I look at health systems as a complex human being, a dynamic human being, continuously changing human being. You need to understand this entire structure of health systems before we can say that I need evidence. Last concluding point is, there is so much evidence, right? Again, as a clinician, we follow subjective, objective assessment and planning, right? So subjective is what you observe, what is said. You observe what's happening on the ground. That is subjective clinical assessment. A good clinician develops those skills of knowing the diagnosis when the patient walks in. So you invest in those skills of observing on the ground what exactly is happening. Then a good clinician again asks only one test to diagnose and confirm the diagnosis. He does not ask 100 tests. It's like a machine, a sniper versus shotgun. The shotgun is you approach. So you need to first have a clear assessment based on your subjective experience of the practitioner to ask the right question. So the evidence is generated because donor is asking you to generate the evidence, not the person who is going to take the decision. So it is the person who is going to take the decision based on his subjective assessment of the ground situation. He will ask evidence for him to decide which treatment, which intervention is going to be effective. So yeah, these are a few of my comments from a clinician perspective on health systems. Okay, thank you.
Thanks, Dr. Reddy. Again, you have raised important points, in terms of funding, who is deciding the research topic, and how do you involve the governments, the policymakers, the important stakeholders, commissions into the research program. Dr. Neha, so I know you from 2017, you have been involved so much in health and wellness centers and mid-level providers and those sort of things at that level in the policy making sort of thing. Now, I would be keen to understand from your perspectives, when you were involved in that work, so what sort of evidence did you actually look for? Did you generate that evidence? Did you collect that evidence? Did you access that evidence already existing? Or it was a mixed kind of approach? And what Dr. Reddy said, understanding the problem first and then looking out for solutions, or looking out what is existing there and what works best, So any perspectives on this?
Thank you so much for that question. So first of all, I would like to thank you for this opportunity of sharing the stage with this, I was telling, so the League of Extraordinary Public Health Experts, and also from whom I've learned a lot and worked with them and learned under their guidance as well. So regarding, as I think most of the major points for evidence generation as well as accessing those evidence have already been answered by sirs. So while we were planning, as sir was already there, and he was one of the person guiding the national health policy as well as developing the guidelines for comprehensive primary health care based on the PHC task force report. So as we say, evidence generation is nothing new. It's not something which is new to the block or it's a newly invented thing. It was there. However, the path is also not very straightforward when we talk about generating the evidence from the field and also applying it during the implementation of any national health program. So the one issue with the entire evidence-based practices has been between that sometimes they call it that it is over prescriptive, being not very relevant to the complexities or any kind of state-specific context or uncertainties, as sir mentioned about the emerging situations and the challenges being the first step for identifying a step or implementation of any national health program. So there was a need even at that time when it was felt that we also need to integrate and apply more methods, how to generate more evidence from the field, and also the uptake of these evidence-based health services, healthcare interventions towards the primary healthcare. And as we say that evidence generally is classified into four main things. Like we have a research evidence, we have the person's evidence, we have the perspective, the people, the population evidence, and also the fourth one is the contextual evidence, which is most important. So in our country, not one size fits all. Every state have their own contextual issues, their challenges, their priorities, which makes it very important to generate that context-specific evidence so that we can accordingly address those situations or those challenges. So even while designing or planning the comprehensive primary health program. For example, we were introducing a new cadre of healthcare workforce, community health officer or the mid-level health provider. So kind of first a secondary review or a rapid evidence was undertaken to understand how this cadre of health workforce, this mid-level provider or non-physician health workforce have been able to provide these services. And as Sir said, the two main challenges faced by the community was one, overcrowding, and the second one, the lack of specialized care. So to cater to this gatekeeping behavior, to understand the care coordination through these mid-level providers so that we can control this overcrowding at the higher level, so that we can help giving the primary level services at closer to the community at the sub-health center level. These evidences which were there were very important for designing their roles, designing what this community health officer would be providing, and also organizing the entire service delivery mechanism at the primary health care. So we say that generally when we talk about evidence-based practices, we talk about identifying a problem or identifying a priority for us. Then as a second step, which Sir already highlighted, was information system, to gather the information on the same and to also appraise the information, that what all can be used. And once we appraise the information, how are we going to apply that? How are we going to use that? And this whole loop is not complete unless we evaluate. Evaluation is a very important step in closing the entire loop, when we have to see that what we expected is also the observed result from that intervention. And in case there is some discrepancy and there is some differences between what we expected and what we are observing through this intervention, then there is a call for further reading the thing or further undertaking a research and implementation research, or to understand that what are the enablers or what are the barriers which we need to focus on. Similarly, as a first step of comprehensive primary healthcare, the comprehensive primary healthcare also defined that an expanded range of services would be delivered across these health and wellness centers, where beyond the RCH communicable and acute simple illness conditions, we would also address non-communicable disease, which was the first package as defined by the comprehensive primary healthcare. So when the population-based screening for common non-communicable disease was launched, then initial step only, a system preparedness assessment was undertaken across 17 states to understand that at each level, at the community level, at the primary health care level, at the secondary level, and at the state level and at the national level, what are the challenges or what are the identified issues or concerns amongst all relevant stakeholders. And as rightly Sir said, that many times the evidence generation is not from the perspective of the community, but from the other perspective. So the focus was to also understand that how much are we able to reach to the community, which is the basic principle of comprehensive primary health care, to deliver free of cost, affordable care to community as closest as possible. So based on that dipstick analysis for 17 states, some of the issues were highlighted by community members as well, which were further addressed through different advisories and state level meetings, and it was facilitated from the national level across state and the district level. This is one of the things. And what happens actually, as it was already highlighted by Sir, that generally we have multiple resources or knowledge which is already at the level. But it is more important how to integrate, how to utilize that for program implementation. So we have people's knowledge which is very much over there, which is available. However, we are not using it through the decision making. However, we have started talking about people-centric approach now. But that component is we need to explore how we can reach out to that component and start integrating into our decision-making systems. The second is experts, public health experts and researchers' knowledge, which Sir also again highlighted that it is very important. There is a disconnect. So it is there, it is available through papers, through publications, but then again, linking them to the people's knowledge is very important. And the third one is the implementers' knowledge. So currently what happens when states who are implementing, we are generally identifying them at the recipient ends, that they are getting the knowledge, they are being trained, but they are implementing, so they are also an expert. So this knowledge also needs to be acknowledged. So this gap between the implementer and the researcher, this interface needs to be strengthened.
So this was somehow, some of the components are addressed, but a lot more is to be learned, and we are still evolving in making and in strengthening the health system and ensuring that comprehensive primary health care we are able to deliver as we envisage. But still a lot more is to be done.
Right. Thanks, Dr. Neha. I mean, yeah, we will touch base upon, because you said that you looked into 17 state data and you worked with them and you found out data. Maybe we'll touch back again once we complete the entire panel once, so that means that there is some gaps in evidence, right? So that's the reason why we have to collect more information, new information. So maybe we'll touch base, once we have this perspective. I'll come back to you again. But thanks for talking about the different kinds of evidence. That sort of helps us to understand it's not only the scientific research, it's not only the statistical data, but also the citizen voice and evaluation evidence, which is also key for decision makings. Thanks, Dr. Neha. So now, Dr. Indranil, maybe based on your expertise, can I ask you, how do you see strategic or results-based financing can be ensured for primary healthcare system?
Can I, thanks, first of all, thanks for having me here and among this very distinguished set of speakers, and I'm really honored. Is it okay if I deviate a bit from the strategic financing bit and performance-based systems and give you a short take on how overall data architecture and some of the critical reflections on the larger question of how to use the data in the primary care setting? Is it okay if I spend 2 minutes on that?
Sure, Dr. Indranil, please go ahead.
So, because I thought there are certain concerns I need to raise here while we are in this very important session. One of the thing is, see, the way we look at autonomy I think one of the important pillar of having a robust evidence is autonomy to data and institutions who are generating data, putting up evidence. And we see, for instance, if you look at, say, NSS, a National Sample Survey, the National Family Health, NFHS Family Health Survey, over the time, there has been limited autonomy to these institutions, and this becomes an important deterrent to data. For instance, if you look at, say, some of the 76th round of NSSO, which could have been very critical because it came with the health round, the consumption expenditure rate data, the data showed, probably it showed certain disturbing trends, and the data was dropped. It was not shared in the public domain. Why am I bringing this point? Other important point I want to bring in, the National Family Health Survey draws from a very internationally established, well thought out, tested and tried DHS framework. It needs to be provided certain levels of autonomy. We see that that autonomy is being to some extent curbed. These are important tendencies we need to look at and be aware of, that this could lead to or provide deterrence, or it may be a challenge to get correct kind of information which can inform policy making. So we need to be aware of this. We are very far away from really performance-based models. Why? Say we don't have, for instance, very basic data of how many primary care providers you have. The digital mission is trying to do that. That's one of the first stage. But if you look at the architecture, it says that for private sector, this is voluntary. It's not merely coincidence that this data is not there. We don't know how many hospital beds in the country we have, how many primary providers we have. We need certain basic data to be able to do anything which is performance-based, say strategic purchasing. We talk a lot about strategic purchasing, but we have very little evidence to do some of this. And this needs to be, I think there are efforts to do that, but there needs to be also autonomy in what you are doing. Second point I want to bring in, how do policymakers respond to evidence? That's also very crucial. If you look at the discourses related to COVID deaths in India, the policy, the researchers said our disease estimate, death estimates, mortality estimates are far higher than what is being reported. This is a common evidence. Whoever involved in primary care delivery knows that we have limitations in the reporting structure. The death registrations are limited across countries between rural and urban areas. The policy response have been refusal, a confrontationist type. Why is that so? We need to also go back to why this kind of response, because we see from the perspective of implementer or policymaker, this is an assessment of the performance of those who are on ground performing. Rather, a good health system, be it primary care or any other kind of health system we are talking about, needs to understand data as an indicator of the challenges that we are facing rather than an assessment of that performance. I think that incentive structure needs to be changed. That's why we see our ANMs, our Anganwadi workers, our ASHA workers not being able to report correct kind of information and data. These are known facts, do not come up in public domain as often, not much in the so-called scientific literature. I think these needs to be thought through. These are not mere coincidence. So without certain basic transparency, autonomy, and also to be able to use the data to improve performance and look at the whole evidence as a wing, as another wing of a service delivery rather than an assessment of performance, we would not be able to create a model of performance-first financing. So my submission would be to this panel to really look at the issues of autonomy, independence. Many of the research institutions that are created and funded by government does very important research, but we need to probably provide greater autonomy to this institution so that we can have good data. We hardly, as researchers, we hardly have access to performance data of the government. Even if we ask, I'm not going into any specifics, even if we ask, we are denied access. We need to talk about these things in public domain and ask for greater transparency and access. And research community has to be trusted for the work they are doing. I'm not saying as researchers we are perfect. We have our fallacies and flaws and biases. But I'll stop here. I may not have answered your questions, but I thought it is important to raise some of these issues and share some of my thoughts.
No, Dr. Indranil, that was very useful. And Dr. Rajiv, I will get back to you on some of these questions that are raised. Dr. Arnab, do you agree with what Dr. Indranil has said about data usage, government not taking the data, transparency, and you want to add something more to this?
So very briefly, I agree with him as a researcher. As a researcher, when I sort of, try to talk to people about, access to data, the first thing that I, as a researcher, am told is, no, this is not data that you have access to. You need to come through the appropriate channel. We sort of, now the appropriate channel often essentially means speaking with, people who are rightly and or wrongly, I don't know, asked to sort of administer the data, to keep the data sort of sanitized. Often, these days when we collect data, and when we collect data for, not government data, but project-based survey data is available in the evening for data collected in the morning. So the speed with which data collection happens has increased significantly. Yet we find that, for all sorts of reasons, data release strategies that are administratively adopted are essentially delayed. And by the time you get access to the data and you sort of do any research on the basis of that, and we present that data as researchers, the same individuals who are guarding these data will come back to us and tell us, well, you're looking at data from 2018, 2015. These are no longer current. So it's, in some sense, I think the data question and the data protection question, I think, is sort of, I think the horses are out of the stable. There's really no way that researchers are going to be currently relevant unless they're a part of the project team that's collecting the data. And that sort of raises questions about, I don't know, the decentralized culture that we want to popularize and have norms. I mean, after all, much of the data collection happens on taxpayers' money. And if we deem this to be a valuable enough activity, and I certainly agree with Indranil and also with many of the panelists who have come before and talked about data as its relevance in terms of, contributing to conversations, to discussions. But I think I'd just like to also nudge in a direction that I don't think we have sort of gone to as yet. The general sort of, conversation that, when we think about as researchers, often the question and the motivation for that conversation starts with a prior within either the research community or the clinical community. And the executor of that research is also again within that research, or, as Dr. Krishna Reddy was sort of separating between the bench and the clinical side. But I think something that Dr. Neha sort of brought up, which I think is very relevant, particularly given the sort of ecosystem within which primary healthcare is provided, is also the stakeholder. So I think conversations wherein, communities are the target for evidence creation, communities have the basis for saying, well, isn't this something interesting to try? Often these kinds of questions come from the researcher or from a policy perspective. But I think if we are in this mode of sort of introspection, I think it would be relevant to sort of start seeing whether we can bring on board. It's not like the community doesn't do anything. The community does innovate, the community does make choices, the community does try to negotiate some very complex sort of questions. I mean, I think the one moment that I think has been very evocative for me has been, as a part of a study team, I was at a PHC in Chitradurga in rural Karnataka, and I was representing myself as an individual. And this woman came up to me and saying, look, sir, you have come in this car which goes behind the government vehicle. Can you tell me which program you're coming from? So I said, what do you mean, which program? I'm a professor at a university. I've come to understand what happens. So I said, no, sir, you are being given extra attention. My child has a hole in her heart, and I have these 3 different cards under which I have different conversations on which I can get health insurance. Can you help me access this? Now, this is a question I don't know who answers. I mean, is it is this a question of design? Is this a conversation on evidence? Is this a question on data? Is this a question on introspection? I don't know. I mean, this is something which happens and it will keep happening. And I am reasonably sure that I don't have a very good answer to this problem. But I do think that, this is something which is very symptomatic of the, problem that we are trying to address. So I think I just leave with that. I think we've had a really strong sort of set of comments, and I think a lot of ground has been covered. And this is like a small piece that I'd just like to add to the puzzle.
Thanks, Dr. Arnav. I think what you and Dr. Neha have talked about community engagement as a part of your talk, of what you said. I think that becomes a separate topic in itself. And of course, I agree about transparency, evidence, the community engagement, the gaps. We are looking back, not because we don't like what you're saying, but because the screen is behind. So everyone is looking at the back. Sorry for that. So now, Bob, I mean, you have been hearing about these discussions till now. So do you want to add some perspectives globally, whether the challenges are similar, whether the challenges are slightly different, whether there are any new sort of things that you want to add to this conversation?
Yeah, thanks, Praveen. And I've been listening to the conversation with great interest. And obviously, like many of the issues would be the same, you know, in Africa, for example, in our countries. And I mean, what I've heard in the conversation, I suppose, is different types of evidence, you know, that are needed. And I think, I mean, what's been mentioned is, first of all, you know, evidence to be for policymakers and systems to be responsive, of course, to changing health needs. As I think the example that was given was around the increase in non-communicable diseases. A number of people have spoken about the need to be responsive actually to the users of the health services and to be responsive to people's experiences and needs and expectations. And then a number of people have also spoken about the model of care and evidence on whether primary healthcare has the capacity, for example, to deliver on certain services or not, and what those services should include and should look like. And then others have spoken about evidence on how to implement policy, you know, into service delivery, and how does one do that, and what are the factors involved. Then others have spoken about, which is interesting, is, you know, like we have this, when we talk about comprehensiveness of primary healthcare, I mean, we have it with a big C and a little c. You know, so I think if one thinks about, I think one of the speakers spoke about the need to see, to have the big C, you know, that comprehensive primary healthcare has to involve sort of multi-sectoral policy and action and community engagement and attention to the social and environmental now determinants of health, and that we often forget, you know, for evidence on how do we do that. And certainly in Africa, we do that really badly. So I suspect it's the same in India. I don't know. But we don't do multi-sectoral work well, and we talk a lot about community engagement, but we don't do it that well, I think. And then I also liked the lens, you know, seeing the issue through the lens of the health system, and not through the lens of diseases, and taking a systems view, and that is something, as you know, Praveen, that we struggle with globally. You know, in fact, you know, when we put in proposals for research that takes a systems view, you know, and looks at sort of cross-cutting issues of service delivery, they often are unsuccessful because people like to fund diseases. You know, and in fact, I think, you know, that there was launched a sort of another global campaign. What was it? The 30 by 2030 campaign, that even the WHO spoke about, but saying that, you know, funders, 30% of all research funding should go to addressing the strengthening of health systems rather than diseases. Yeah, so all of these, and then I think actually interesting that, because a lot of people spoke about these policymakers that we're trying to engage with, and because, you know, and the fact that they're often very influenced by the politics, and that as a politician you might not want actually the evidence to be put out there that might make it look like you haven't done a good job, and the different forms of evidence that policymakers actually pay attention to. And of course, as we all know, the actual research evidence is really only one of the many forms of evidence and influences that they, we know this in South Africa, you know, the country of state capture, that there are many influences on policymakers and politicians that are not necessarily evidence-based. Yeah, so, and I liked also I mean, having said that, I must say that there's also been great value in my context of what we might call sort of embedded research. So you actually, you work with the policymakers to do the research with them that they think they need to make sensible decisions, and that actually is a very good strategy if you've got good policymakers who are looking at sensible issues, and of course then they immediately use your evidence in changing or redirecting policy. So yeah, so I don't know. I mean, I've sort of more given you more of a sort of summary of what I've heard. There were two interesting bits that kind of made me raise my eyebrows a bit. I suppose about the differences between how things might be spoken about in Africa versus India. I mean, the one was this thing about people. The two issues are people struggling with being, the overcrowding. That, of course, is the same in Africa. But the other thing was that people were wanting specialized care in the primary healthcare space. I don't think people would say that in Africa. So that was interesting. And I don't know quite what that means, but I mean, whether India has a particular sort of obsession with specialists and specialized care, or whether people are actually saying they just want better quality care, from well-trained generalists, in the primary healthcare space. And certainly in the African context, our focus is on trying to get well-trained sort of medical generalists into the primary care space rather than specialists. So that was one. And then the other interesting thing was somebody mentioned that 70% of your healthcare is in the private sector and 30% in the public sector. It's the complete opposite in Africa. So certainly in South Africa, 80% of healthcare is delivered for good or bad by the public sector, and of course, 20% in the private sector. And we are officially the most unequal country in the world, unfortunately. But most African countries, there would be the reverse. So that's an interesting aspect of India that I hadn't appreciated. And the person's quite right. When we look at the health system or the district system, we actually need to look at all health services in that system, and especially important for you guys not to ignore, of course, then the private side. So I don't know whether that helps, Praveen, but those were some of the themes and some of my reactions to what has been said.
Yeah, thanks.
Yeah, is that helpful? I don't know.
Yeah, it is helpful, and it's summary as well. It's seeing for the contrast and the similarity between two health systems. Now, you raised a very specific and important topic of specialized healthcare, which Dr. Neha and Dr. Sanjeev and Dr. Rajiv, everybody sort of talked about. So are we at the primary healthcare facilities? Are we talking about public health and primary care as a primary healthcare, versus are we talking of including specialized care, which is secondary and tertiary care within the primary healthcare? So again, that's what the feedback was, and that's what your research or the research mainly says. And then Dr. Bob's sort of comment whether is it specialized care or is it good quality of care? So that's again a contrast that we can discuss about. Other topic that really came out was around community engagement and what needs to be done for community engagement. So again, Dr. Reddy, if I can put you on a spot here. So there are, you have been sort of working at the interface, you are a clinician, you are a researcher, you have been involved in stent development with Dr. Kalam. You have been also working at primary healthcare improvement, health systems improvement, and you work a lot with policymakers also to translate this sort of things. Now, how do you see communities and civil societies to play a role in ensuring PHC programs are delivered effectively?
Yeah, that was the point thought I was getting when we talked about the mid-level health workers, actually. At least as a clinician, if I try to understand why patients seek healthcare from a particular doctor or from a particular healthcare provider, I mean, I get patients from say 300 kilometers just to consult because they trust. They trust that I may be giving them the best care. So that is one element. Suppose we are imposing a mid-level health worker as a caregiver. But if that person does not trust the mid-level health worker, but he trusts the informal RMP, he will not come to the primary health center. So did we really understand the health-seeking behavior of our people when we design these delivery systems? That is one thing, because it is continuously changing. I mean, the people's expectations are continuously changing. They want, when they want healthcare, that means they want 24/7, because they don't know what is acute, what is not acute. I mean, they can't, suppose somebody has a mild chest pain in a diabetic, it can be a threatening acute MI. So how does he know that it is a primary care problem or a secondary care problem or a tissue? Because again, I think we are not getting out of that mindset of a provider-centric thinking. Today, patients may not, I mean, if they have a chest pain, the mindset has changed that they have to go to cardiologist. They have a headache, they have to go to a neurologist. How are you going to change this mindset of a patient in terms of their health-seeking behavior? So unless we design, I mean, because if you look at the private sector, why the online systems have come and why they are providing teleconsultation, why they are providing drugs at home, why they are providing diagnostics at home, why innovators are developing point-of-care diagnostics so that I can diagnose my COVID sitting in my home, because they're responding to the unmet and increasing needs of the health people. I mean, people's need does not remain static. So that is, I think, one area we are missing in terms of evidence generation, that we are not listening to the voice of the people. I mean, what, and just observe them. I mean, why there's, suppose you are giving free care in public sector, why they are not seeking that free care, despite their financial hardship, because health is so personal. They don't want to take chance when it comes to health. So these are some of the elements, I think, in terms of what we design. Suppose we are creating, say, health and wellness clinics, but for the same, suppose the people, how do they perceive these health and wellness clinic? How do you build the trust which is not existing today? I mean, there is evidence. Again, evidence is there. Say, for example, the Tamil Nadu primary healthcare centers, when they made just drugs available without failure, that means there is no stock out. That is enough to build the trust. There is no stock out. And when we took a feedback from the people at the ground level, they said, if the doctor is there in the time during which he was supposed to be there, that is fine for with us, even if it is 3 hours. But even those 3 hours, when we go to the center, he is not there. So how do you, so this is the basic gross level evidence that unless these systems are fixed, even before we think of evidence, there is, again, in clinical medicine, when patient is crashing, we don't seek for ECG, X-ray, CT scan, and MRI. We shock the patient. It is like that. I mean, there is so glaringly evident when somebody is inspecting a patient, how they are moving around. So first, how do you tackle that, which is glaringly available? I mean, you don't look for additional evidence. So once you respond to that, what is evidence, then you start generating more deeper evidence to fix higher problems. I think, yeah, this is my take again as a clinician, because we have to listen to these patients to understand why they travel 300 kilometers to a city when they have a good primary care system. That is the question. I mean, I think for a researcher, that is a strong question. What is the behavioral science behind this health-seeking behavior?
Right. So yeah, and community is critical, no doubts about that. Dr. Silpa, sorry, you have been waiting for long. And as a PhD researcher at the ground level, and then, you have might have come out with new innovations, new evidences, and you might also try to sort of advocate those findings with the government, the policymakers, to include that in the policy. But then again, there could be challenges that you might or your team might have faced. And are there any potential solutions or challenges that you want to, first maybe the challenges and then maybe any potential solutions that you or your team might have devised, or you have read, or anything that you want to talk about, any good practices that we can take home from here?
Thank you so much. I first of all would like to thank the organizers for giving me this opportunity to be on this panel and share my experience. So I come from a research organization who's been working in the area of research since 1975, when I wasn't born. So since then, the organizations are working in collecting evidences, training primary healthcare providers based on the evidence, and trying to link it up with the program and policy makers. So my experience was basically the challenges that we faced when we tried to understand what are the perspectives of quality of primary healthcare providers. So we did some pieces of research in different states of India. I had a chance to meet Dr. Sadanandan that time in Kerala when we conducted a study there to understand how the primary healthcare providers are looking at quality, or what is the meaning of clinical guidelines for the public health providers, what is the meaning of protocols, and how they value evidence-based research versus experience-based practices. And we did the similar research in other northern states of India. So all these explorations gave a base to understand how the health system needs more attention in terms of building capacity of these healthcare providers to look at evidence-based practices. And then we designed a few intervention research projects in terms of building the capacity of auxiliary nurse midwives and other staff nurses and medical doctors from the PHC. The first experience when we tried to discuss this with one of the state officials was that means if you are going to conduct the intervention research and trying to have research built in the training program, it's like a trial and error. So you want to use our trainer as guinea pigs. So that was also one reaction when we tried to start this project. But slowly we could involve some of the district health officials as well as the state level health officials in designing those health programs, in designing those training programs. So there was a committee to understand various protocols, and then we could sit together and then have the whole training manual ready for their own health providers. In terms of actual implementation of these training programs, also we involved all the public health sector health providers, right from the medical officer of a PHC to a specialized doctor from a district hospital as trainers. And when we tried to involve these different cadres in the entire training program, that definitely gave us better results, having more response and support, not only from the district, but also some of the state health officials. And they were involved in all the stages of the research project. Like I said, right from designing the training program to communication of the findings of the research. And based on that, we have been seeing that the research organizations should learn primarily how to conduct, of course, a good quality research. And when I say good quality, the words may sound very simple, but it's not that simple, because most of the times the research is equated with conducting big, large-scale surveys, which may not be enough. So one has to look beyond the numbers when you are saying that you've collected some findings or data from the research. So that's important to have the qualitative research also blended with your large-scale surveys when you call it a research. And it's equally important how effectively the research organizations or researchers can communicate these findings to the program or policy people. Because if you speak too much of a research language, it's not really accepted and it's not really that easy to comprehend. So the way we say that it is important for researchers to have a good health communication skills with the community, it's equally important that they learn how to communicate with the communities as well as to the programmers and the policy people. So it's two-way communication is equally important. Otherwise, the researchers or the academicians and policy and program people, they work
They cannot work like two different distinct compartments. So it has to be an iterative process when we call these words like evidence, research, training, program, and policy. It's all like a circular process, I would say, and it has to feed in each other continuously. That's what we have been seeing that can really work. If you work on that process, maybe from starting from a small thing, like start small or take a smaller step, work with the district people and try to build in the state level, because it takes time. The researchers need to have a lot of patience. Like even if you have shown a particular evidence that it has worked at a district level or at one state level, like in India, you have to really have a large scale studies to show that this is the robust evidence on which the program or policy should be based on. So it takes years probably. Like for example, even if we are working in the area of capacity building of the health providers since last several years, more than a decade, it still takes time for us to reach at that level to make any substantial change when it comes to changing the training programs or the pedagogy of training programs that we have, maybe at pre-service or even in-service trainings of healthcare providers. So it takes time. So that patience is very important even for the research organizations. And I would say from the other side, from the policy or program side, they need to create more space for the researchers and probably need to have a person who will have that understanding of what research means, because there is always a gap between the research and policy, like everybody else has said. And it's equally important to have a person who's experienced, expert in research, and who can really have effective communications involving the research organizations or researchers on board. And just last point I would like to make, that even if we generate a lot of evidence, there is no single portal or there is no space where whoever wants to access research on a particular subject, whether it's primary healthcare, whether it's a specific disease-related research, there is no directory or there is no portal where policy or program people can access these pieces of research easily. It's very, very difficult for researchers to access data, but it is equally difficult probably even for the policy program people to access good evidence which is generated from research organizations or researchers. Thank
Great.
you.
Those are all very good points, Dr. Silpa, about how policymakers and the researchers, the academicians, the evidence generators, so if I may say, they need to work together. So Dr. Rajiv, next question to you. Again, now you're free to talk whatever you want to. You're no more wearing that hat, but it's 12 o'clock now. It's 15 more minutes. I think the audience has a lot of questions with them. So we will wait for 15 minutes before we conclude this panel, and then we can say your questions here. So yeah, Dr. Rajiv, what are the ways in which you feel policymakers and governments can work better with researchers and academia? Dr. Silpa has said few important points, but again, those are crucial. And how do you think that can work out?
Thank you. I should thank Dr. Shilpa for not commenting on what my response was when she had contacted me as a policymaker. Why did you say that then? Okay, now, remember, data is not neutral. I keep saying that transparency in public will never go unpunished. Let me give an example. We know about a country who hit the outbreak of actually 2 coronaviruses for 2 months and caused all this trouble. And what did they pay for it? Nothing. So I don't think that I can't compare that to another country, that is South Africa, which had an excellent genomic sequencing system and picked up Omicron first. Now we know that many of the countries who imposed a ban on South Africa, travel ban on South Africa, actually had cases of Omicron before South Africa had, and South Africa paid for it by their transparency, by publishing that data, which was a very responsible behavior, but look at what they got. Let me give another example from closer home. A state in India had 2 outbreaks of Nipah virus. Nobody even knew about it. So many people died, nothing happened. A bat that carries Nipah virus flies not more than 50 kilometers. The next outbreak was picked up in Kerala, which is 4,000 kilometers away. It's highly unlikely that the bat would have gotten to an Indigo flight and landed in Kerala. Which means that there must have been episodes along the way in which it was not picked up. Kerala picked it up. And what did they get? A ban on export of fruits and vegetables to the internationally for 6 months. It took a lot of effort from my side with WHO, everybody. So, data to a policymaker and more to a politician has severe crisis. Again, let me. You need to stop me when I finish, because this is something that which something that all researchers need to understand. When 2016, when I took over as health secretary for the 3rd time, I did a public health explanation to my minister, told them about the 2002 SARS outbreak, how China hit the SARS outbreak and how they paid for it and how we'll be transparent. And she agreed, not knowing what she was getting into. And 2017, we had a huge dengue epidemic. I mean, across the world it was there. I mean, all over the world it was there. I mean, all over Asia it was there. And unfortunately, the transparent system that we had put in place was revealing the data and revealing the deaths. The minister got roasted in the assembly because she said, when the opposition said, when we were in power, the number of deaths and number of episodes are so few. Now that when you come to power, you're handling it so badly that, and at a personal level, in my new role, I went to a state where the health secretary was an old colleague of mine who knew my character. And she said that we cannot let this fellow do this research in my state because I'll be in trouble. And I was not allowed to do that. And the data actually came out in the next NFHS. So, so I understood why that was not happening. So data is not neutral. Now, but on the other hand, how do we make policymakers comfortable with this data is also important, because again, as somebody called up asking advice on how to control the dengue epidemic that was breaking out in her capital. I said, be transparent about the data, because unless people know that there's a problem, unless we acknowledge there's a problem, there is no way you can control an epidemic. She said, no, then my minister will kill me. I said, otherwise your people will die. That's the only difference. So the value of data and the value of being transparent, or a malaria outbreak, and if the data doesn't get out, that is expensive, and that realization need to happen. Now, why should policymakers help researchers? Someone tell me why? Anybody? What is it for policymakers? Okay, I'll answer the question myself. Now, we come up with exogenously determined research questions, which might be of no relevance to the policymaker. Now, one of the things that we are doing a fellowship program. One of the things that in the first 2 cohorts, we let the researchers choose the question, but we realized that we're getting it wrong. And in the next cohort, we've decided that the policy research question will be framed in consultation with the policymaker of the of that state where they're working. We don't know how it'll pan out, but I think it's important that the research question has to address the need of a policymaker and has to be framed in consultation with them. I know it's difficult. I know it's impossible to meet health secretaries, and even if you meet them, they're so bloody arrogant that you don't want to talk to them. But sorry, we got to work with that, But what will happen is that if we do a situation analysis, if we identify a set of problems, which we did, and play it back to the government, they will say, no, we don't want this. We don't want this. Of the 5 that we gave, 2 were picked up. That is the exercise that we need to do. So unless we are able to create value for the policymaker, it is not good. You're not going to get that. You're not going to get that kind of cooperation that you're looking for. Second one is a point that that was mentioned here, which is embedded research. Now, how do we train people in the system to work either as principal investigators or as co-investigators so that they see a stake? So my question of how do we get policymakers interested is when you show that there is a benefit for them by working with it. And I know that most of us have contempt for bureaucrats and that kind of this thing, but you need to get over that and then and learn to work with decision makers and demonstrate to them that there is value in working with us. Other than that, the question that I would ask would be, why should they work with you? I know you don't like my answer, but
No, very useful insights, Dr. Rajiv. I think that why is very important for us and to understand and start advocating and working with them together. So I understand we are 10 minutes to the end where we will take the audience questions. But before that, there's a lot to discuss. I mean, there are so many points here that even half a day or full day of this panel with this eminent panelists will not be sufficient to cover all these broad topics. Do the panelists have any questions for each other on any of the context or any of the issue or any of the topic that has been raised by any of you? Does anyone have? Yeah, I see Bob raising his hand. Yeah, so maybe Bob and then, yeah, Dr. Singh.
Yeah, I suppose, thanks. I mean, one question I have is, like in a lot of other disciplines, and I think there is a cardiologist, isn't there, on the panel, the clinicians themselves are involved in performing research. And I think somebody also spoke earlier about the fact that there's a gap between the researchers and the clinicians. Now, in the primary healthcare space, our clinicians, are often nurses, mid-level workers, even community health workers, et cetera, and they don't seem to have any sort of academic, if one can put it like that, sort of activity. They're sort of a discipline without that aspect. Now, and that's the same in South Africa, I think, although the nurses are developing a little bit in terms of research in that space. But we also have another discipline in South Africa of family medicine, which is more in the sort of the medical side, I suppose. And they are beginning to generate quite a lot of research in the primary healthcare space. And I know in India, you also have family physicians, so I think they're a bit thin on the ground. But so I'm just wondering, how do we go about enabling, in a sense, the discipline, if one can put it like that, of primary healthcare and the people doing it to actually generate evidence and research, so that it's not just external researchers, or research organizations or public health people coming into their space and sort of doing the research.
Anyone wants to take that?
Yeah, in fact, I mean, at least from experience, I can mention in terms of what type of habits we try to inculcate among the medical professionals and the nursing professionals, which ideally need to start from the medical education level and the nursing school level. See, as a clinical professionals in today's health systems, just having the clinical science as a knowledge is not sufficient. That means you need to have a good clinician, need to have the science of medicine, the science of management, the science of behavior, the science of information, the science of health economics, and the science of health policy. Then only you can have a good clinician. Otherwise, you are not a good clinician. I mean, because my every decision, a clinical decision, is not dependent only on medicine. Now, today it is dependent on who is paying for this patient. Whether this proven technology I can give to the patient is not decided by my medicine. Similarly, as a medical student, I mean, so this is how, in fact, we have a daily morning 8 to 9 academic session as a culture in our system, where we discuss not just medicine, but also the entire health systems aspect. Again, at a personal level, at a personal health level, because that is another confusion that exists. At a personal health level, how you be responsive. At a population health level, how you are responsive. For example, if I apply the cost-effective analysis for a person, but the analysis is done for a publicly funded population health, how do you resolve this conflict? Right. I know at a population level, if it is government funding, it is not cost effective. But as a clinician, when I am advising to an individual, And if I don't inform that this may be better, so there is a dilemma. So I think answering the question, it's a good question because every clinician, because see, the most intimate interaction in a health system is patient and clinician. There's nurse or the doctor, whoever is providing that. Everything else evolves around these two people's interaction. So a clinician has to have this comprehensive knowledge of entire health system, not just the medical system. I think that is, and that should be begin in the medical schools, in the nursing schools. Not once they become doctors. It's very difficult to change their mindset once you practice. You don't need to learn these things, right? You're already earning money and you don't need to. So yeah, this is the root cause is that we are not revising the medical curriculum, the medical education curriculum, the nursing education curriculum, the public health education curriculum. Like today's public health, if they just know epidemiology, that's not enough. I mean, they need to know health information science. They need to be a good researcher as well. So I think, yeah, the root is there actually, unless we change the medical education and public health education and policy administrator education and learning. I mean, if we have the Labasa, if every IAS officer, if they are going to manage a health division, department in the Ministry of Health, if they don't go through a 15 days of orientation to understand what is health system, they will do disservice. I mean, there is the difference between an RMP practitioner and a formally qualified practitioner is that RMP knows what works, but they don't know what is the root cause. That is the difference between a self-styled cardiologist versus a formally trained cardiologist.
Right. No, Dr. Krishna,
To respond to Bob's question, the problem is twofold. One is primary care physicians, unlike in his place, where the general practitioner is a 3-year is a postgraduate with a 3-year professional training, who is also trained to conduct research. Two, so which means that in our system, there's no system for formally training our GPs on research. Secondly, lack of access to funding, because they need research support. The only system that pays for it in India is the research fund that is available under the project implementation plan of the NHM, which sadly is very rarely used by the states. And my experience is that it's only used by general practice, by primary care physicians who have a training in MBH or MD community medicine, but that's very rare. So most often you find that money is not used, but this is something that I think we need to work on.
Dr. Sanjeev,
Show the slide. Do you have it uploaded?
yes.
All right. No, till they do it, I want to take you further. Let's split the community. And we have used this word very often, community engagement. And what is community? If I go to the village, what is community? Whom do I talk to? Anybody I meet in the village. You have to fine tune it to individuals and families. Then I know whom I have to talk to. It is individuals and families who need care. In the name of community, we have created community health guides. Now we have created Ashas, we have created Anganwadi workers. We pick up one person and make him part of the system. Right. So we need to, thank you. So we need to, now I just want to show you a few pictures. People are recipients of healthcare. This mindset needs to be changed. People are responsible for their health, and super specialist knows everything. And then there is a specialist. You are ignorant, I'll tell you what to do. Then there is another one. I'll tell you what to do, and community knows nothing. We have to change this mindset. This is 1986. Book by David Morley. The mindset has become worse. Now you are going to provide family care through MD family medicine. We are going to the Western route. We are not looking at clinical officers in Africa and other countries who are not fully trained doctors. They are given training for 3 years and they provide day-to-day care to the families. This is what we need to do. We need not health service providers. We need health coaches. Because it is me If I go as a patient, who will take care of my health? Doctor is not as concerned about me and my health. My family is more concerned than the doctor. We have to turn it upside down, look at what individual needs and what family needs. And all of us know when we fall sick, we are the first ones to take care of it. Then we tell our family members, they take care of it. Then if at all we decide to go to a health service provider. So this needs to change. And what is the value? And Lancet Commission on Health. There are very few studies. I request health economists to do more studies. In 1 year, in India, 213,000 crores was contributed by family in healthcare. Women take care, we all experience that. 175,000 was contribution of women. And we also do, men do a little bit, all of us sitting, most of us on this side and on the other side, we contribute 38,000. How does it compare to government expenditure? Government expenditure, 169,000 crores is the total expenditure. And the latest NHA, National Health Account data shows that. So family today is contributing 50,000 crores more than the total contribution of central government and the state governments put together. What can family do? I will quickly take you through. This is for maternal and child survival. If you want to save lives, you have things which can be done exclusively at home. You don't need any healthcare provider to do that. And this is a UNICEF slide I used in one of my presentations in Kenya. Then you need system to deliver services, immunization, vitamin A, etc. Family decide whether to go and avail those services, whether to come for the next dose or not. Then the third category is when you are sick, you need healthcare provider, go to hospital or health facility. Again, you decide when you will go and where you will go. So family is the core of healthcare. We need to move from community to family. And similarly, hypertension, what can be done at home? You cannot manage hypertension sitting in hospital. You have to come to the home and you have to come to the individual. I am hypertensive for last 17 years. I have gone to cardiologist once. I have gone to my family physician 10 times in 17 years. Rest of it is managed. You can say you are a doctor, you can do it better, but that's the situation. For anybody who is suffering from chronic diseases, what can be done? We need to revise national policies and standard treatment protocol. Neha remembers, we developed 12 standard treatment protocol. Where does it stop? We went up to primary healthcare. We looked at what a PHC physician should treat in hypertension, for example. But we need to go home. What can be done at home? All standard treatment protocol guidelines developed should be starting from and ending at home level. Then restructure training of doctors. Every doctor, healthcare provider needs to understand health is at family. You need to empower individuals and family if you want to see sustainable results. Engage private sector. That point has already been highlighted by Dr. Krishna, that 60 to 70% of primary healthcare is in private sector. It comes to 80% when you talk of secondary and tertiary level care. Thank you so much.
Thanks, Dr. Sanjeev. Now, again, involvement of private sector, it's a big topic in itself. Maybe another panel discussion with our distinguished panelists. So any questions from the audience, please? Yeah, ma'am, you can ask the question. Yeah. We'll want to do this. Okay, fine.
Yeah, so my basic question is regarding the sort of the point that was focused by Robert also on the specialized thing. Because can India afford a specialist as far as medicine is concerned? Because first of all, the cost of becoming a doctor is exorbitantly high, and most of these people are focused on metros only and urban centers. And to consult, for example, today if you go to a specialist, say a 15-year-old kid, doctor basically says that you basically get him consulted to a specialist like for a skin disease, or for that matter, even a eye disease. 20 years back, it was completely unheard of. So that makes it completely, barrier is way too high. And with that, we are opening way too many AIMS, for example, and that is reducing the quality as far as because we do not have that sufficient faculty. We've already seen with the IIMs, IITs, once they started opening up, their quality went down. So can we India afford it? Because the doctors basically are quite expensive to come up, and they are not focused in the rural areas, and with that they become specialist. So where will obviously, from the rural area, the most of the stuff is going to get concentrated towards metros, and the hospitals are going to get overloaded, and that's why we are seeing that the clinical. Yeah. So that's my point, is that is the focus on specialist is a correct solution for India.
Right.
One small comment and a question. Thank you. Having spent 38 years in public health service in public health system, I feel that over time, in several decades, the graduate doctor has been empowered less and less, and the education system is somehow encouraging him that he is incomplete unless he does a PG, and that attitude has to change. That is one comment. And second is that that even in cities like Delhi, there is hardly any referral system. The various health institutions are not connected. They have no responsibility towards each other. And so this leads to a big mess and mismatch between the demand and supply. My question is that when a piece of evidence or comes out of research to a policy maker or a policy implementer, is there any SOP that how is this to be dealt before it is accepted or rejected? And what are the criteria for rejection? Does such a system exist in the government in various states? If yes, sir, please elaborate on that. Thank you.
So,
Thank you very much,
Yeah,
sir,
sorry.
for asking that question of making a comment. May I know your name?
My name is Dr. Vijay Rai.
sure.
Thank you very much. So I'm Dr. Deepika Saraf, and I'm former Deputy Director General ICMR, and I have done my pediatrics. I did my MBBS, and then my pediatrics, and then my doctorate in community medicine from All India Institute of Medical Sciences. And also then I tried to do all those things that were laid down by Dr. Reddy. So I don't know if I write my CV, how will I match it with anybody? So that is the problem. We cannot have so many qualifications. One person cannot have it. Probably I had it, I don't know why. And I still, am struggling many things. But the question, so whatever you said, I mean, I resonate to it so much. What have we done for the MBBS doctor that we have in India? We have created many cadres, wow. And we are strengthening them, and we are weakening the MBBS doctor. At every conference, the MBBS doctor is not mentioned and is weakened further. Where is that chap going to go?
Ma'am, is that your question?
That is my
Okay.
question. How are we strengthening our GPs?
Yep.
The way NHS has done in US, are we doing anything about it?
So maybe we can
I think,
respond to these questions.
Yeah, I
first.
think
Yeah. Too many
most
questions.
of them seem to be thrown at me. Let me clarify that the NSSO question on specialization refers not to PHC, but to OP care. So the question asked is that, like, those of you who have seen NSSO know that it refers to various other things. One is separate questions are asked for OP care and separate questions are asked for IP care. So when you say specialist care, it is not weird. The question was not targeted PHC, but as you know, in India, primary care is provided even in AIDS. So the question was OP care, and so that was the response. So Bob, I wasn't talking about specialists being there in PHCs. That's one. Two, there is a disconnect between various parts of India in accessing health services, and Dr. Reddy's and my comments unfortunately relate to the southern part of the country where the damage is already done. You know, so the superstition about one, that only doctors can treat, two, that only specialists can deliver services is already done, and the vested interest is so high. Sorry, the vested interest is so high that it'll be difficult to change that. It can be changed. I don't have the time to explain it how it was done, but now the point that was made: how do the general practitioner of the OECD countries manage this need? Because the demand for specialized care is there also. The trust between the assigned population and the GP is so strong that the patient will not think of bypassing the GP whom he or she trusts and going straight to the specialist. But the referral system is good. So the advantage would be, the best way to handle this would be to, one, build the competence of the primary care provider to diagnose properly. Now, a chest pain is an MI or a gastritis. It's for the call is for the primary care physician to take and respond accordingly. Even if it is an MI, how do you do the pharmacological management first and refer? Train that person. Right now, he or she will not do it. She will only refer, and by the time you reach a cardiologist, the person is, well. Now, so the question would be, a solution to that would be, building the referral system. And again, a huge vested interest that stymie efforts at doing it. I don't have time to go through it, why it happens, what the thing are. The point about the data being collected, analysis done in the state shows that about 23% of a field worker's time is spending writing reports, which nobody uses. So the digital mission, is one thing that we tried. Again, I don't want to go how it's been. At present, it is messed up by the MIS requirements of the government of India. The data that is generated is one of the principles of data collection is that no data that will not be used should be collected. Second principle is that the person who collects the data should benefit from it. Otherwise, the data will never get used. We violate both in our system. So one of the things that we're trying to do is how to work with the data collection, the health management information system, which is what this refers to, work around with so that we reduce the load on the frontline worker by weeding out non-essential items, to stop data entry and start data capture, which means that you have to digitize your working system. Hopefully that will happen. 3, generate a dashboard that is available to the A&M, to the primary care doctor, to the district and the health secretary or the director of health services, so that the analyzed result of the data is available to help them with the decision system. It's going to be a long time. And again, one of the states where I offered this to, my response was, sir, this is election year. Please don't look at HMIS. It'll come out the truth. Don't do that. But we have been able to get some other states interested. Hopefully, this project should be able to come up with a better managed HMIS system.
Right. Thanks, Dr. Rajiv. And there was another question about monitoring system for evidence that is already generated. Is there any system for that?
That also has to be thrown at me.
No. Yeah, ma'am, Dr. Neha, yeah. Because I thought
we are, and as was mentioned, we are disempowering the doctors in primary healthcare system, which is very unfortunate. And as a patient, those of you who have gone to, I once went with my daughter to an emergency service in the US. The first person who saw her was a medical assistant. She had an injury on the back. We were suspecting coccygeal fracture. So, and what did he do? He ordered an X-ray. After half an hour, orthopedic surgeon came. The whole examination, everything had been done. She just spent 5 minutes. There is no fracture. You need painkillers, and painkillers were provided. Within 1 hour. We were back home. Similarly, in Africa, I worked in Malawi, Uganda, and Kenya. Who is the first person? And I came to know after 1 year being in Kenya, it was a clinical officer. OPD was crowded. He was seeing patients, managing them very well. And he is not an MBBS doctor. He's a clinical officer trained for 3 years and providing all the basic services. And if you remember David Morley's book he has written based on African experience, 95% of patients who come to primary healthcare don't need a doctor. So what we need to do is empower downwards, not disempower. Now you are thinking of family medicine physician who will do MD in family medicine and provide primary healthcare. You are chasing a model which is expensive, has been tried in many developed countries, and the cost is going to skyrocket if you follow that route. Unfortunately, we are on that path. Thank you.
Thanks.
I suspect it will come here, but I was hoping that Praveen will deflect it somebody. Now, where does policymaker get to see the evidence? What is this situation? What is the venue in which the evidence that is generated by research in research institutions ever reach policymakers? We don't have a system for that. So unless the policymaker insists on this data being presented, nobody will collate it and present to the policymaker. So the issue then is that the evidence hardly ever gets presented to the person to evaluate. Two, the research that is done has nothing to do with the needs of the policymaker. Therefore, he rejects it. He's too busy doing anything else. And three, the system by which the research itself is conducted based on the need of the policymaker. And two, point somebody made, which is Dr. Shilpa made, is that, yeah, Shilpa. So, Dr. Shilpa made, which is, how do you analyze this, literature review and then present to the policymaker so that in a language that he or she can understand? Lastly, it is not enough to generate evidence. It's also enough. There's also a need to generate demand for evidence, which we have ignored.
Great point, sir. And maybe it goes to you, ma'am. Just a continuation of that. How is evidence synthesized? How is evidence monitored? Does NHSRC has a role, or is there any other body, that kind of takes it through?
Thank you so much. So a major part was already conveyed by Sir very well and very crisply he explained. So yes, evidence plays a very important role whenever we are designing or thinking of planning or a policy. And it, as Sir rightly said, the integration needs to be there, the demand, the evidence generation, then how are meeting what are the needs of the policymakers, or what are the needs at that end, and what are the needs of what is the being done by research organizations. So now when the government, like Ministry of Health, has now established this implementation research health system strengthening platform, thinking in this directions only. So I would just like to share that here, as I said, that states are generally taken up as recipient of this thing and not as important stakeholder or experts, because they are the one who are implementing any program in their particular states, and state specific context varies. It's not one size which fits all, and there are complexities and uncertainties across all domains. So we also have to think on those contextual evidence background. So through this IRHSS platform, actually the priority setting is like the initial step, where the priority setting exercise is being done with research expert, public health expert, the policy makers for those respective states, and the implementers at the state level, to first identify what are the key research priorities or the problems at respective states,
related to population, the disease burden or program implementation. And once we identify a list of these research priorities, which have been identified by all the states and respective public health experts, these are converted into research questions with the help of our research public health experts and research experts, which are then further vetted by the policymakers at the national level, at the NHM level, to understand which of these research topics are of their importance and can be undertaken as an implementation research through several partners and research organizations. So once a list of identified questions is identified and these research questions are finalized, they are also put up on the website for on a public domain, so that people can go through these research of these implementation research topics, and based on their areas of interest can apply and can work with ministry and can work with NHSRC for undertaking these research implementation research. So that's it.
Thanks, Dr. Yeah, so now we have crossed 6 minutes from our scheduled deadline of 12:30. There might be many burning questions. So would we want to take one last question, panelists? Okay, please. And so no questions. Whatever questions we have, maybe if you can suit us those questions, we will get feedback from the esteemed panelists, and we will be developing a blog and a report of this, and we will be sharing it with all of you. So if there are any burning questions, any questions that you feel are relevant to this topic, please do feel free to let us know. Yeah, sorry. Yeah.
Okay. I'll just share one example. What we did in one of the district was that, because we are talking so much about the data and how it feeds back. So we had a training of all the nutrition rehabilitation centers, staff working in that particular tribal district. So we tracked their data for about 2 years, and whatever findings we could generate based on their own data, we had a workshop for them to sensitize them to look at their own data. The session was how to read your own data and how to question yourself. So that particular session was like an eye-opener for all of them. So I just feel that it is very important to show them this mirror, that what your data can show yourself, the good things and the gaps. So just one example was that I think about 60% of the children who were discharged from the NRCs, they did not have the expected weight gain when they were discharged. So what implications this finding has for the entire district? So we could explain to them that means that all those 60% are going home without reaching that threshold of quality that they should gain at the NRCs. So then the onus lies to the other stakeholders from the community, the Anganwadi workers, the ASHAs, the ANMs. So we involved all of them to understand what coordination they need. And then we gave them the knowledge required for in terms of community-based nutritional support that they should give, malnutrition aspects and the updates in the knowledge. So the very first step was to show them their own data, find out the gaps. So I think this is very important. The similar thing we did for the ANMs, that if you have the data, the example was one column about premature rupture of the membrane. So that was shown blank for 2 years. So what does that mean? So was there no case who had this complication in your own PSC, or was that a gap, or was that not understood by the ANM that what is to be filled in here? So such small examples we did at primary health center level, district level. We also had a national level workshop on looking at your own data. So that was just an example that I wanted to share, that at all levels, people need to understand how to read your own data and what it implies to you at different levels. So I think research is not a different language. It should come from within their own system and day-to-day work.
Right, feeding back to the people who collect the data. Dr. Reddy, do you want to have a last comment, brief comment?
Just a last comment in terms of linking the evidence with the policy making. I mean, just like there is a clinical evidence and how it gets linked with the clinicians in terms of the practical application. So the evidence generated by pharma companies, they market it to the clinician, the evidence. That means somebody has to advocate that evidence. Similarly, evidence generated by a unsponsored university clinical evidence, it never gets marketed to the clinician. So there has to be, I think, a link between evidence and one is policymaker asking for evidence is the most simplest thing. But many times policymakers do not know what questions to ask. That means then somebody has to generate the evidence and then sell that evidence to policy. I mean, that is where the policy advocacy comes into picture. typically the researchers think that they are not fit for advocacy. So they need to rethink because there is nobody else to advocate your evidence. So you also may have to wear that hat of an advocate of this evidence, if it is compelling and if it is for the public good, because otherwise a sponsored thing, suppose a private industry sponsors evidence generation, say Pfizer generates evidence for incorporation into policy, then it becomes then they will push everything to market that evidence. So that is where the lobbying comes into picture. So yeah, just thought how to actually sell this evidence. Who has to sell this evidence? That is where I think the public, civil societies, they have to be engaged to sell this to the policymakers. The policymakers listen to that because it translates to votes. So that means researchers have to connect with the civil societies to bring pressure on the policymakers and in a way which they can understand. If it is going to benefit them, this evidence, and they have. So just a thought that there is a missing link between the evidence and the policy making. Somebody has to sponsor.
Right. Great. It's a great way of summarizing the discussion, and the importance of the advocacy agency, if I may say that. So it was great discussing with all of you. Now I request Lakshmi to talk about to give the vote of thanks and thank all of you for the incredible knowledge that you have shared with all of us today. That's me.
Thank you all. We've spent the past couple of hours delving into evidence-based primary healthcare, particularly the gaps therein. And I'd just like to summarize my thoughts on this, which I hope you all share. At the core of primary healthcare is a clear and often a revised understanding of health as not just a matter of disease, as many of our panelists have already spoken of, not just a matter of identifying disease and then getting rid of it, but the positive aspects of a person's being and functioning, well-being, and so on. And primary healthcare also emphasizes the need to center people, and these people are not necessarily patients. They may be patients, that's if they are in the disease aspect of the big spectrum of health, but they are most of the time not patients, they're people, and they have around them many vital stakeholders who make their lives meaningful. And these vital stakeholders are sadly not always acknowledged. There is some official recognition of some stakeholders, and they are officially appointed as community representatives and so-called volunteers, sometimes paid and so on. But the vast majority and really the most intimate stakeholders are the ones that we don't really recognize, family and friends and so on. So today's discussions, including the questions, some of the questions were verbalized, and I'm sure there are many other questions in our minds. I know for sure that some questions could not be asked, so there are some questions that have not been verbalized, but I'm sure all of us have questions in our minds. And we've heard some solutions. The biggest message that I think we heard was the need for consonance. Consonance between needs and solutions to those needs, and consonance between people and the services that are required and so on. So I'll just list out a few of the points that that struck me. So the first thing is that primary healthcare is different, or is a superset of clinical research, which is often talked about as bench to bed. But as I was thinking about this, I came up with many more words beginning with B, not all of them in English. But when you think about primary healthcare, there are lots more Bs that you have to think about. There's the bed, the bench, yes. But there's also the block, the basti, the bike, the ballpark, the buddy. I'm using a Telugu word here for school. The body, which is the Bengali word for house, the boardroom, and the board itself, which is to mean food. And so all these Bs have got to be taken into account in considering primary health care. And a lot of conversation took place about the inclusion of people and how to include people. And what we found is that the path is not straightforward. We knew this, but there's no denying it anymore. We realized anew that policymaking does not take place in a glass room with microphones attached. So it's far from transparent. And therefore, I mean, since it's not transparent, then and it can be pretty complicated. We see that there are lots of human factors in addition to all the factors that we consider neutral and objective, such as numbers, data, which we realize are not really objective and neutral anyway. So lots of human factors, notably preconceived notions, people's strong ideologies and the ideological clashes, hegemonies, communication gaps, advocates or lack thereof, and prejudice most of all. So the way forward, if we are to achieve effective, efficient, and equitable primary healthcare, is a way to come together. Not easy, but it really requires a lot of proactive shedding of prejudice and a certain openness to the multitude of disciplines that come into play in primary healthcare. So that's what we need to be doing. We need to look beyond numbers, we were told, and we have got to recognize the need for effective communication. The gap between evidence and policy, and then the gap between policy and implementation were talked about at some length. And some of the questions asked were about monitoring and a focus on specialists, an inordinate focus on specialists, and how evidence is examined and then utilized or not utilized by policymakers. We found a few solutions. I mean, what should we do? We're all sitting here and lamenting, as we have been for a while. There's good reason to lament, no doubt, but what can we do? What we can do is to infuse as much neutrality. When I say neutrality, I'm really talking about autonomy and independence into data collection and analysis and dissemination as possible. And then that's as policymakers and researchers. And then how to reach the policymaker who has not been, not many complimentary terms have been used for policymakers today, but how to reach the policymaker, because reach the policymaker you must. So create value for the policymaker, not at all declared as an easy task, but how should we negotiate the path? The path is to be negotiated by understanding the needs of the policymaker and the people, and bridging the gaps through information, better communication. As one of our panelists said, we need policy advocacy, not just evidence. It's not as if there is no evidence that people can act on. There is a lot of evidence, but people are not acting on it because they're not getting hooked. So it doesn't resonate with them. So we need to ensure that we create that resonance, and we may have to advocate our own work. This is not an easy task for many researchers, but we have help in the shape of ourselves, but also in the teams that we have in our research institutions. So we need to advocate the policy, create value for the policymaker, and the percolation of insights needs to be facilitated. Insights from the different worlds, the worlds of academia, the world of communities, the world of clinicians. So we need to percolate these insights. And again, the percolation of these insights will require a little bit of a clearing of obstacles in the path, so communication flows better and there is openness to receive. We know that one of the solutions going forward is to focus on building the competence of the general practitioner to diagnose and refer. So better communication, an avoidance of duplication of expertise and activity, and to streamline data collection, data management, and the utilization of data. So that's where we are. We will continue this discussion in possibly a slower and more staggered manner, with your questions coming in and answers going back. So I'd like to thank everyone involved today, the panelists, of course, who've taken the trouble to come here or participate virtually and provide us their valuable insights into evidence and policy, the gaps therein, and implementation. And I'd like to thank the TGI team. I want to make a special mention of the impact and engagement group, the communications group, the IT group, and the admin group for having organized this event. And I think we'll all agree that it's been really smooth. well organized. And the PHC research team, of course, is at the core of this all. So great job, PhD research team, and thank you to them. I want to again make special mention of two people who are not here, but had a lot to do with this event in the preparation and the content of this event, and they are Manushi Sharma and Devaki Nambiar. So these people were, okay, Devaki Nambiar has sneaked in, so I'm, yeah. So Manushi couldn't be here because she's at this moment a patient, not just a person. And we trust that she's getting a lot of excellent primary health care where she is. Devaki couldn't be here, or thought she couldn't be here because she was one of those vital stakeholders who may or may not be acknowledged. She was dealing with her family sickness, but she is, so that's great. So thank you all for being here. Thank you for your participation, your questions, your conversation. Thank you to our panelists online for their contributions. We will now close unless Praveen wants to come and say something else. No. Thank you very much. See you at lunch. Thank you.